Yeah. So stroke, we know, is the second leading cause of death worldwide, and it is. No, so I think I need to exit the full screen 1 second so I can. Okay, sorry about that. So it's the second leading cause of death worldwide, and it is actually the leading cause of serious and long-term disability. And if we take into account that about a quarter of stroke attack are recurrent attack, we can only imagine how there will be more and more people that will develop, that will, you know, if they are lucky enough to survive a stroke, they will develop long-term disability. Nowadays, we have 2 approved acute therapy for the treatment of stroke, the thromboectomy and the thrombolysis with the recombinant tissue plasminogen activator. However, there are severe limitations with the use of this therapy, and these are mainly dictated by the time window. Indeed, if patients are lucky enough to reach, you know, the emergency care within 3 to 4 hours at the maximum, and this intervention can start within 3 to 4 hours from the onset of stroke, there is an increased likelihood of those interventions to be successful. Otherwise, the longer we wait, the decrease is the likelihood of successful intervention. So there is a clear urgent need for the development of new therapies that can treat stroke even at, you know, longer time window above the 4 hours time point that at the moment we have available. How can we develop new medications for the treatment of stroke? Well, we can use either in vitro or in vivo studies, and we can use in vitro and in vivo models to mimic stroke. In particular, when we talk about in vivo model, the main models that are used to mimic stroke are used in rodents, mice and rats, and they involve the occlusion of the middle cerebral artery. And that's because about 70% of the stroke that people experience are ischemic stroke. There are 2 main ways of occluding the middle cerebral artery. One approach is a permanent PMCO model, which is used to mimic those strokes that are caused by a permanent vessel occlusion. And they are achieved by performing a small craniotomy on top of the rat or mouse skull, and then directly and permanently coagulate the distal middle cerebral artery. These models are used to test or to measure the volume of the infarct damage, but also to measure functional and behavioral outcome. And so they can be used for measuring, for testing the efficacy of a novel therapeutic for the treatment of stroke. Another approach is to mimic strokes that are actually caused by a transient vessel occlusion, and so a transient middle cerebral artery occlusion, and these are achieved by inserting a filament through the common carotid artery of a mouse or a rat, and then the filament is passed into the brain and reach, you know, the middle cerebral artery. The filament is then left in place for 30 to a maximum of 120 minutes. And through a laser Doppler, it's possible to monitor the cerebral blood flow. And in particular, it's possible to monitor the drop and the reduction of blood flow once the filament is inserted and is taken in place. And then as the filament is removed, we can observe a reperfusion of the cerebral blood flow. Similarly to the permanent middle cerebral artery occlusion, this model is used to investigate changes in the volume infarcts, but also functional and behavioral outcome that are a consequence of the occlusion. Using these models, we've been able to test several pharmacological interventions. In particular, we focus on the use of carnosine, which is an endogenous dipeptide, and we investigated the neuroprotective efficacy of carnosine. We've been able to use both isoform L and D-carnosine, and we perform dose response, time response studies in which we look at the effect or the efficacy of carnosine in showing neuroprotective properties. As you can see here, both isoform L and D-carnosine are able to diminish the infarct volume, and that was true when carnosine was given at different interval post the onset of ischemia, but also when carnosine was given by different route of administration. So that, is even more important because it does help us to the translational aspects when we are trying to develop a new pharmacological intervention. We are trying to develop intervention that can be used or delivered to human in easier or multiple ways. Furthermore, we use in vitro approaches as well, in vitro models to test the neuroprotective efficacy of carnosine. And we've been able to demonstrate that both isoform L and D-carnosine are able to show neuroprotective properties by reducing the generation of free radicals, but also by reducing the cytotoxicity and increasing the cell viability when neuronal cortex neuronal cells were exposed to a toxic environment. So we've been able to show that carnosine does offer neuroprotective properties that can be then translated into human studies. But if you remember at the beginning of my talk, I was telling you about how I have a strong interest on investigating mechanisms that drive chronic pain condition. And stroke is one of the conditions that does interest me. And that's because we know that about 30, if not even 35% of stroke survivors, they do develop post-stroke pain. So those patients are lucky enough to survive a stroke. They do develop neurological impairments, unfortunately, but on top of that, they do also develop a chronic pain condition. And this chronic pain condition is extremely debilitating for them. It does, like post-stroke pain stroke survivor that develop post-stroke pain, they do experience an accelerated decline, fatigue, more depression compared to individuals that do not develop pain following a stroke. But also, and dramatically, there is an increased risk of suicide that that involves these patients. And that also because the experience of post-stroke pain, unfortunately, does hugely compromise the recovery of these patients because they are experiencing the pain, feeling the pain, they are less likely to be able to participate in the rehabilitation session. Despite being so common and despite being so detrimental, post-stroke pain is still, unfortunately, extremely under-recognized and highly untreated. And, it's quite important that there is more and more attention that is focused on the treatment or the development of novel therapeutics for all these patients that again, are lucky enough to survive a stroke, but then develop several impairments, including developing post-stroke pain. But what really pain is? Well, we know from the International Association for the Study of Pain that pain is defined as an unpleasant sensory and emotional experience that is primarily associated with tissue damage, or we describe in terms of tissue damage, or both. And if actually we, for a moment, step back and we think about the major function of pain or the physiological function of pain, we need to consider that the physiological function of pain is actually a protective function. Under normal circumstances, pain is there to warn us or to remind us that something is wrong. By acute experience of pain, for example, we put our hand on a hot stove, we feel the pain and we have the reflex of taking the hand away. day, or if there is, a more prolonged experience of pain, it's because, there is a physiological process that is not working properly. So, for example, there is an inflammation ongoing, and, there is a repair that is needed, and so on. And in particular, how the physiological protective role of pain is important and is evident to us. It's unfortunately demonstrated by those individuals that show congenital insensitivity to pain. And as you can see here, hopefully, there is, in this little hand of a little baby, there is a huge tissue damage. And so that's because the little baby puts, his hand on a hot stove and not being able to perceive the pain, didn't perceive the warning, didn't get the warning signal, didn't get the something dangerous is ongoing, and so completely burn his finger. I don't know if you can see here, or if I'm sorry, Zoom message is on front of it, but there is another picture of a young girl that basically has a hole in her cheek. And that's because she stabbed herself with a pencil, because while taking this action, she couldn't perceive the pain associated with the action. And then again, is another, strong evidence how pain in normal circumstances has a protective role. But the problem is when pain loses its protective role, the circumstances are not normal anymore. There is a tissue damage, or there is something else that is ongoing and is now changing the transmission. And pain is not anymore protective, becomes chronic, is experienced, very debilitating, and is experienced, don't want to say every day, but quite often, every other day, or once or twice a week, and then it becomes a disease. Indeed, the inadequate pain relief is now a global concern for a patient and practitioner. Pain, especially when it's, experienced in a chronic way, is not always cured, and it does require constant, continuous medical management and attention at the same level as any other disorder or as any other disease process. So it is, is becoming more and more evident and important how the experience of chronic pain does require, more investigation and understanding from the research point of view. And also, if we think about in numbers, how many people worldwide do experience pain, or if I just look at, within one country, like the UK, for example, we're about 40% of the UK population. So we are talking about almost half of the UK population is suffering from persistent pain. Persistent pain that, debilitates the individuals, decrease the quality of life, is not well treated. Again, there are a lot of factors that point us at the direction that we definitely need to investigate more on chronic pain. And, if then we go back and we put that into the account of just stroke, we need to consider about 30% of stroke survivor, half of the, almost slightly less than half of the stroke survivor will experience chronic pain together with, all the other individuals that experience chronic pain. We definitely need to pay more and more of our attention into understanding the mechanisms behind. But what's post-stroke pain? Post-stroke pain has been defined or classified as a form of neuropathic pain that results from the damage to the central nervous system. And the mechanism that are thought to be behind post-stroke pain are thought to be the same, if not similar, to the one that occur following spinal cord injury or multiple sclerosis. Stroke survivor, they do experience post-stroke pain in a way that they experience a burning, aching, penetrating, lancinating, stabbing sensation that is ongoing continuously or quite often into their daily life. However, it's very common, it's very debilitating, but the pathophysiology is still highly unclear of the mechanism behind post-stroke pain. Stroke survivor, because of the different impairments that the stroke can cause, can't respond, they can't be offered all the analgesic treatment or pain relieving treatments that are available. So the choice of treatments available for post-stroke pain survivor is very limited, and also like we know that they do not respond well to opiate-like drugs. And that's because following the stroke, there is a damage into that descending inhibition modulatory system that we all have, and that were like, you know, the opioid-like drugs work on. New connections are made in post-stroke in a patient with post-stroke pain, and unfortunately, they can't respond. They do not respond well to opioid-like treatments. So there is a clear unmet clinical need that we need to close or shorten the gap as fast as possible, as much as possible, because of how debilitating it is for these patients. What's, again, post-stroke pain, how it is experienced? Basically, post-stroke pain is characterized by an increased sensation to either a noxious, painful stimulation, so development of hyperalgesia, or a sensation, a painful sensation to a stimulus that is generally non-noxious, so development of allodynia. You can see here, like normal pain responses, we have those stimulation that are non-painful. We don't perceive it as painful, but then if there is an injury occur, there is now an increase, like a response to those non-painful, like previously non-painful stimulation, or an exacerbated response to already painful stimulation. And that's what, we talk about pain in humans, so post-stroke survivor, etc. But how do we put, again, all of this back into the context of a preclinical setting? Or how can we use our preclinical setting to investigate post-stroke pain? Well, we can investigate pain relatively easily in animals by using tools that are available. And what we can do is we have different tools to measure a change in the animal sensory threshold. So we can, for example, expose the glabrous part of the hind paw side of the animal to an eating source and measure the latency. How long does it take for the animal to remove his paw from the heat stimulation? And so we can measure the development of hyperalgesia over time. Similarly, we can also measure development of allodynia by applying calibrated von Frey filament, which are also used clinically to measure pain in humans, by applying a specific force to the glabrous part of the animal hind paw, and over time look if there is any change from a non-response to a response now because of development of allodynia. So what we've done here was to basically use our permanent and transient middle cerebral artery occlusion models and then look for development of pain. And as you can see here, prior to any ischemia, there is no, animals show what we call a normal sensory threshold. And then over time, only the animals that received permanent middle cerebral artery occlusion do develop hyperalgesia, do develop an increased sensitivity to a thermal stimulation on the paw that is contralateral to the site of the injury. Similarly, those animals develop allodynia, so a painful response to a stimulus that is generally non-painful over time following the onset of ischemia. And I want to point out that, again, there is a difference between the ipsilateral and the contralateral side, and the animals are showing a painful response or changes within their sensory threshold only to the contralateral side from the injury. Similarly, when we look at development of pain in the transient middle cerebral artery occlusion model, we've been able to show that there is development of hypersensitivity in the contralateral side following a transient middle cerebral artery occlusion. And furthermore, we've been able to show by MRI imaging in mice that following transient middle cerebral artery occlusion, there is actually, you can see here, there is actually a loss in the cortical thalamus connectivity at the resting state phase. So again, there are all different ways how we can measure development of post-stroke pain in animals, and then use different tools to translate that into more a clinical scenario or compared to the clinical scenario. We know that neuropathic pain, which is what post-stroke pain has been characterized as, requires for its generation and maintenance, require the intervention of the matrix mellopeptidase protein, which are a family of zinc-dependent endopeptidase. And we know that actually carnosine does elicit its neuroprotection action by inhibition of the matrix metallopeptidase, in particular MMP9. We've been able to demonstrate, an increased expression of MMP9 in the site of injury, and then a reduction following carnosine treatment. So the next question for us, of course, was, does carnosine in any way affect post-stroke pain? And so what we did was, again, go back to our permanent or transient middle cerebral artery occlusion model, and then test any pharmacological intervention with carnosine and measure the pain that develops following it. And as you can see here, in the blue dots, we have animal that underwent permanent middle cerebral artery occlusion, and then over time developed both allodynia or hyperalgesia in the contralateral sites, in contralateral hypo, and animals that were treated either 30 minutes prior to the ischemia or 24 hours post the ischemia did show a reduction in the pain developments in the hyperalgesia or allodynia that develops following a stroke. Similarly, we observed this in both male and female mice. So female mice as well showed, an improvement on the neurological score following carnosine, but also a reduction in the development of pain following permanent middle cerebral artery occlusion, and similarly in animals that underwent transient middle cerebral artery occlusion. So again, we do have carnosine that not only offers us the possibility of showing neuroprotective properties, but also shows analgesic or reduce the pain development in animals that do experience or develop post-stroke pain. Analgesic properties of carnosine that seems to be independent by the neuroprotective action, because are related in animals that were tested 24 hours post, were treated with carnosine 24 hours post stroke. Now the tissue damage, the brain damage occurred, so the neuroprotective action of carnosine has already happened, it's gone, and now the analgesic action of carnosine is the primary driving force. We know that animals that do develop post-stroke pain show an increased expression of key mediators of pain, like calcitonin gene-related peptides, and we know that carnosine treatment does actually reduce this expression of pain mediators, neurotransmitters. So again, there are different, to conclude, I think there are different evidences here that show how we can test the development of post-stroke pain in animals that undergo transient or permanent middle cerebral artery occlusion. This is not only manifested by development of allodynia or thermal hyperalgesia, but also by increased expression of pain neurotransmitters, but also, most importantly, we do have the possibility of using a neuroprotective agent and study their efficacy and function as analgesic pharmacological intervention for the individuals that do develop post-stroke pain. And with this, I would like to thank you all for your attention, but also my collaborator, Professor Rashad Majid and Dr. Sarah Bajain from the University of Sheffield. Thank you.
Thank you so much for your presentation. Now floor is open for the questions. Anyone having the questions can raise the hand. I can't see any questions. Thank you, Doctor, for your wonderful presentation. So now I would like to our next speaker, Dr. Alexandra Prince-Lim from Sheffield Halman University, United Kingdom. Can you hear me?
Yes.
Yeah.
Can you hear me?
Yeah, I can hear you.
Can I use share my
Yeah, you can share your screen now.
Okay. Can you see the presentation?
Yeah, yes, I can see. Can you keep on presentation mode?
Hold on. Yes, of course.